Hello, this message and video is for all my students in Sleep A to Z, or now known as Night Shift Academy, because we shifted over to the United States. Anyway, this message is for you, especially for those who are taking the RPSGT exam. I have made another video earlier to discuss about the importance in titration, especially CPAP to bilevel to ASV titration. Okay, but now I want to discuss many different things in regards to the RPSGT exam. First of all, the RPSGT exam is geared towards a group of techs who are already practicing in the field of sleep. And so in the field of sleep technology, there are fundamentals that you must meet in order for you to be qualified and be deemed as a technologist. You know, aside from hopefully passing your exam, you should really know the following parameters, right? One, sleep techs must be good in understanding what the doctors are ordering. Okay, so we need to understand the different types of studies, the different diagnoses, right? The different comorbidities, medications. So pharmacotherapy is very important, not to understand it to a doctor's level or a provider's level, but to understand enough what the medications are used for, and also what the medications might impose or affect, how it affects the studies, so that you can also be prepared in what to do when you see certain medications as you start your night. Now, techs must also be able to set up quickly and efficiently, as well as precisely. So my point there is that many techs do not use the I-10-20 system of measurement. And that's very unfortunate, because there is an advantage and there's a reason why it exists. When you place electrodes on the patient's scalp, that is meant to detect particular waveforms or wave patterns. In essence, we need to identify sleep stages correctly. And if you are off when you don't use the I-10-20 system, and you are far off from the mark, from where things are supposed to be placed, you actually affect the sleep study. Either one, you can either not really record the appropriate or necessary wave patterns on particular area, such as delta or slow wave activities on the frontal region and K complex, vertex waves or sleep spindles in the central region, and then alpha and alpha attenuation towards the occipital region of the brain. So when you have things just placed around, it might not accentuate. In fact, it might attenuate possible sleep stages or waveforms that are needed to determine sleep stages. So if I were you, if you're a sleep tech, learn the I-10-20, memorize it, and try to use it, if not every day, then at least once a week, but keep that skill in your pocket. Make sure you know it, make sure you have it. For one, you will not always use the same montage. So we use a contra-ear reference montage in doing sleep studies. You might get sleep study orders to do a full EEG because your patients have possible nocturnal seizures, right? So it's very important for you to know how to do a full EEG setup. And on that note, there's of course other things that you need to have literally always in your pocket, meaning to say you know this at the back of your hand. Okay? Know the different stages of sleep, know the signatures of the different stages of sleep. Okay? Not only do you need to know that N1 has no alpha, or alpha starts to attenuate, and the majority of the epoch is already low amplitude mixed frequency, right? You should also know that K complex, for instance, is a signature of N2. However, if K complex if K complex is observed but is associated with an arousal, you cannot use K complex as a signature for N2. In fact, it denotes N1 or arousal. So, you have to understand the different signatures of different stages of sleep. Wake being wake, you need alpha, of course, and alpha should be the majority of the epoch, meaning to say, when we talk about majority of the epoch, you should at least have 16 seconds of alpha. Okay, and if you have alpha but it's attenuated and then it comes back, it's a waxing and waning, you have to estimate if the alpha is indeed comprising the majority of the epoch or if it's less than 15 seconds. Then if it's less than 15 seconds of alpha, the rest are attenuated, that means that epoch is N1. All right, especially if it's correlated with a slow eye movement. Now, you might also be surprised that some of the signatures in REM is not only having sawtooth waves typically showing up before the actual eye movements, if there are any eye movements. So you have to understand phasic versus tonic REM. So in REM, you can see alpha, but some patients will show alpha in REM. However, their alpha in REM should be slower, 1 to 2 hertz slower than their wake alpha. Okay, so don't be surprised if you see some alpha and you have eye movements as if it's REM. It is REM, but you have to determine that the muscle tone is low and that the alpha is actually below their wake alpha. All right. All right, what else we got? We got deep sleep. So you're talking about delta activity and slow wave, right? But it has to be at least a minimum of 6 seconds or 20% of the epoch. Now, in deep sleep, you can also have sleep spindles. It can show up. You can have, of course, majority low amplitude mixed frequency. Low amplitude mixed frequency is the most prominent background, okay, unless you are in deep sleep already and you have a majority of the activities with slow activity or delta activity. And understand that if you have slow or delta activity, it should be at least 75 microvolts or higher. The frequencies are 0 to 3.99 hertz for delta and 0.5 to 2 hertz for slow wave. So understanding these sleep stages and their parameters, how much are they comprised before you can actually call them a certain sleep stage, is very, very important. Because sleep techs are the one who should be scoring the sleep studies. If you work for a smaller lab, they might ask you to score your studies the night off while you're doing the sleep study. So learning how to score fast is definitely a key to being a good, efficient, and effective sleep tech. All right. On that note, a sleep tech must be also really diligent when it comes to documentations. Documentations before the sleep study, documentations during the sleep study, and documentations after the sleep study. Before you do a sleep study, what are the documents needed? And typically, you will have the patient fill out an Epworth Sleepiness Scale, which has 8 questions that totals between 0 to 24 in total answers. And this is a subjective questionnaire where you will ask patients 8 different questions and they will grade their answers based on how they feel. 0 being non-existent, 1 to occasional occurrences, 2 more occurrences, and 3 it always happens. What that means is do they fall asleep or they don't. Okay, but you can review some of that. But the most important numbers are the range of Epworth Sleepiness Scale is from 0 to 24. If the patient has a sum of at least 10 points in their Epworth Sleepiness Scale, they are considered sleepy and should be sent forward to the sleep lab. and to do an overnight study or get assessed at least. The other pre-study questionnaires are your stop bang for those who are doing home sleep apnea testing. So stop bang is a questionnaire that asks about the patient's sex, the patient's neck, the patient's blood pressure, age, do they have witness apnea, right? So these eight questions will determine if the patient has high risk or low risk for OSA. So it's definitely for OSA. Epworth Sleepiness Scale is not a questionnaire for OSA. That will be a trick question if that is listed on the exam. Sleepiness Scale is to determine sleepiness of the patient, not for OSA. Stop bang is not for sleepiness, but it's for OSA. Hope that's clear. There are other questionnaires called the Stanford Sleepiness Scale. There's Functional Outcome of Sleep Quality, FOSQ, where it asks about patients' sleep quality. These questionnaires are more intimate, and they're not the same and not as widely used as the Epworth Sleepiness Scale and Stop Bang. So there's other questionnaires such as the patient's history, because patients must declare whether they have family or medical history of snoring, hypertension, basically many comorbidities or signs and symptoms that they might have sleep apnea or sleepiness or insomnia, or movement disorders. So the whole gamut, okay, the whole list of sleep disorders. Remember that sleep disorders is the bigger umbrella. Underneath sleep disorders are sleep disordered breathing, which is your apnea, etc. And underneath the sleep disorders are also your movement disorders, disorders that shows patients actually move or even ambulate while asleep. So even clenching up the jaw or grinding your teeth, such as bruxism, periodic limb movements, REM behavior disorder, things like that. Okay. Now you also have parasomnias, like things or activities while they are in sleep. Patients that sleepwalk, sleep talk, sleep eat, sleep sex. These are all parasomnias. Okay. Somniloquy is another one that could be out in the exam. Somniloquy, SOMNI, somnilo, LOQUY, somniloquy. That's sleep talking. There's also what they call jactatio capitis, JACTATIO, capitis, CAPITIS. This is the head banging, usually seen in children. They head bang, they hit their head on the wall to help them fall asleep. But these are different types of these sleep disorders. Okay, and there's a lot more, especially with pediatrics. However, moving along, some of the things that we need to know as sleep techs, aside from these different disorders and questionnaires, are one is titration. Titration is a big part. So when it comes to titration, different modalities, we need to understand the different types of modes, such as CPAP, AutoPAP. Although AutoPAP we don't really use in the sleep lab. Some might, and some won't. Most of the sleep labs don't use any auto CPAP and or auto bilevel PAP titration. Okay. Now the other modes are bilevel spontaneous, which means that the machine will not do anything until triggered by the patient's own breath, whether that's on inspiration or expiration, inhalation or exhalation. It has to be coming from the patient to trigger the device to go from IPAP to EPAP or vice versa. Okay, now when you add a backup rate, that's now called a bilevel ST or a BiPAP ST. These are non-invasive ventilation modes. It allows for the inhalation and exhalation with either a fixed pressure support or an adjusting pressure support, such as in a different mode called ASV, or adaptive servo ventilator. Adaptive servo ventilator you have a minimum and a maximum pressure support and an EPAP. Okay, again, ASV, you have a minimum and a maximum pressure support and an EPAP. If you have an auto ASV or ASV auto, you will have a minimum and maximum EPAP, then minimum and maximum pressure support or IPAP. Again, ASV auto or auto ASV, you will have an auto adjusting EPAP and an auto adjusting pressure support or auto adjusting IPAP. Okay? Now, VAPS, volume assured pressure support. What is this? Volume assured pressure support handles patients that have hypoventilation and are also complicated with other comorbidities such as obstructive apnea and central apnea. So if you're a patient with COPD, also with congestive heart failure, and have some central and sleep apnea, there will be no other good modes to be used except for VAPS or volume assured pressure support. This type of mode helps create a protection for the patient, such as protecting their tidal volume. When you set a tidal volume, the device calculates if the patient meets that minimum tidal volume, and it adjusts on the pressure support, and the other device adjusts both pressure support and also respiratory rate. So you have to input more parameters for the VAPS to work. You can't just put IPAP, EPAP. If it's a VAPS titration if you have a lot of information such as IPAP, EPAP, then pressure support, then you have ideal body weight or tidal volume or alveolar minute ventilation target. Okay, so auto rate or manual rate, they can add rise time, TI min, or inspiratory time in the prescription on how you start. So there's a lot, but the most important thing, the key factor, is that the prescription or the order will say target alveolar ventilation or target tidal volume, aside from the IPAP, EPAP, backup rate, and the TI control or TI min and max or I time. That's how you know it's a VAPS. It has the most number of parameters when you start the study. Okay? Now, going forward, you know what to do before the patient gets there with documentations and the knowledge of preparing for the patients, right? You understand what types of studies, you understand what is appropriate for that patient, simply because you also understand the patient's diagnosis or comorbidities. Okay? Now, when you're doing the study, you understand how to stage or score the studies. You also know how to titrate the patients with different modalities. Now, let's go briefly on the PSG itself, on the recording. Now, running a sleep study requires a lot of technical savviness, okay? Even though for many of us, it's very simple, but for those that are just beginning in sleep technology, the utilization of different sleep systems might be daunting or complicated at first. But remember that when you run a sleep study and you're using whatever type of sleep system, there's only one thing to do. You are going to add a patient and you're going to add a sleep study. Okay? So when you add a sleep study, then it will be based on what the doctor ordered. Is it a diagnostic? Is it a split night? Or is it a titration or treatment study? Once you have that in place, you can already prepare for your sleep study. So if it's a diagnostic testing, you prepare your wires. You go from top down. You prepare your wires, you prepare your prep, you prepare your tape if you need to tape it, right? Then you prepare your paste, you prepare your new prep to prep the skin, or some techs use alcohol swab to help prep the skin, okay? And then you're going to need tapes, going to need tapes, because not only do you need to tape it to the skin, but you will also need to tape it at the back of the ears, as well as taping the wires together. Okay, I don't use tape on the wires because it's harder to clean it in the morning. So just that's a side note. It leaves adhesive on the wire itself. So when you clean your wires and then they're not disposable, it takes some time before you can get out of the lab. So what you do is use a Coban. I use a Coban. When I use a Coban, you're able to wrap around the wires so you have all the wires bundled together. If you have the wires spread out, you can easily get caught while the patient is moving around, and it can pull on the electrode, meaning you're going to end up going back and forth a lot with the patient to either fix the wire or add the wire or replace it, etc. So I suggest you bundle this like a ponytail at the back of the neck. However, when you bundle it, you don't you don't create the bundle right behind the neck. You create a little bit of space, a little bit of slack before you bundle it, so you will allow the patient to turn their heads left to right. So when they go sleep at night, if it's too tight, when they turn their head, it can pull on the wires. That's just based on experience. All right, so when you have these wires, know that it's different, definitely different approach when you deal with adults versus patients, especially, pediatric patients, especially when the patients, pediatric patients are under 5. Okay, 5 and above, they usually are okay, unless they also have any type of delay or neurological disorder, Down syndrome. Then it makes it difficult regardless of their age. But under 5, they're the most difficult ones. And then you also have under 2 months. So you're preemie. You're under 2 months old post-term. That's your 37 to 48 weeks infant patients. If their head circumference is under 30 centimeters, then you cannot really do I-1020. You need to just eyeball it, look at it. Okay. And so on that note, it's actually easier to hook up infants because they can't really fight, and then they can't move much. So, however, there's a lot of challenges when you do infant patients. Okay, now that you're done hooking up the patients, the way you deal with the computer system is that know that when you have a new patient to start, it's always either you add a new study or you add a new patient, and then you choose the type of study, meaning to say you can immediately choose the type of montage. If it doesn't auto-populate for you and you haven't created a montage, this is what they usually call a workspace. Workspace is how you will arrange your montage in a particular way, and you add the necessary filters and you can save it, so that next time you don't need to start from the beginning to create a channel here, channel there, and how you want it arranged. You can just load montage or load the workspace, then you can already have your way of seeing the recording. Okay, when you have all that and when you start the study, of course it's important for you to make sure that the sensors are working fine before you actually run the test and hit lights out. So this is when it's important to troubleshoot right before you start the study. Okay, you troubleshoot before you even start the patient calibration, because once you get the patient calibration, it should just be confirming whether your sensors are appropriately attached, and or do you need to change any filter settings or sensitivities or gain. Okay, other than that, when you do your patient calibration, this is when you ask the patients to relax, calm down. You don't turn off the lights, but have the patients lay on their back so that you can ask them to do some activities for you, and so you can check if the activities that they do in the room actually shows up appropriately in your screen or monitor. So what are the things that you ask the patients? One, you ask them to close their eyes for 30 seconds and then watch if they actually exhibit alpha frequency when they close their eyes. Typically, the alpha shows up when the patient closes their eyes. Okay, and that will be seen on the occipital region. Now you ask the patient to open their eyes for 30 seconds. Know that they will blink. Okay, if you ask the patient to open their eyes and you expect them not to blink, that's going to be very difficult or weird. Patients, we all blink. That's normal, as long as after they blink, they will keep their eyes open and blink again. Okay, so after you ask them to open their eyes for 30 seconds, you should see the alpha attenuation. Okay, after that, you will ask the patients to look up, down, 3 to 5 times, so you can see the deflection. If they go into REM, you will have a reference. You will also ask the patients to go and look from left to right. So you ask them 3 to 5 times. You annotate that the patient is looking left to right, so you can see the deflection of the eyes and how it will look if they will later on show REM. You have a reference point on how it should look like. After you do that, you ask the patients to blink 5 times and then close their eyes. Once they close their eyes, you ask the patient to always relax their jaw. If not, you will have a lot of muscle activity. And what I usually do is ask them to just slightly open their mouth. When they slightly open their mouths, you see that there's less tension on the EEG channels. You'll be able to distinguish alpha and low amplitude mixed frequency cleaner without having to change your filter settings, particularly your high frequency filter settings. That should be at 35 Hertz for the EEG and the EOG channels. Okay. After they blink and close their eyes, you will ask the patient to grind their teeth. Grind or grit their teeth for a few seconds, or ask them to chew or bite down hard. Bite down hard, relax, bite down hard, relax. What you're doing is you're trying to see how it will look like if the patient is actually experiencing or doing bruxism or bruxing at night, or they grind their teeth. So you have a reference point to see if that's exactly what they're doing or it's something else. Alright, after you ask them to grind their teeth, you can ask them to snore or snort, okay, like that, 3 to 5 times, and you annotate. After you ask him to snore or snort, you will ask him to count, because those equate to the difference in the presentation on the snore channel. Snort will look a little bit different from counting. So you know exactly what's happening, even though you might not hear them. After you ask them to count, then you ask them to breathe through their nose only, so you can see how the proper flow channels will look like. Okay, ask them to breathe normally through their nose for a good 5-10 seconds, and then you ask them to breathe through their mouth 5 to 10 seconds. Then you will see a difference. You should see actually an attenuation on the flow channel when they start to breathe through their mouths, but you should not see flattening, because there's still pressure and air moving through their nose and their mouth as they breathe. Okay, on that note, you should also see that the respiratory channels are working appropriately, whether they're in synchronicity or they're synchronized with the flow channel or they're not. If they're not synchronized, that's when you can change the polarity of the channels. Are they going together or are they going against? You don't want to start the study and have paradoxical movement when there's no apnea. The patient is awake. They should all be synchronized with their breathing pattern when it comes to the flow channel and the respiratory channel. Now, after you ask them to breathe through their nose and then through their mouth, ask the patient to take a deep breath and hold their breath for 10 seconds. So why are you doing this? You are doing this so you can ask the patient to mimic a sleep apnea, an obstructive sleep apnea. So what you do is ask the patient to take a deep breath, then hold their breath for 10 seconds, and then move their belly. Move their belly. That's how you will get a paradoxical movement to show obstructive sleep apnea. What I do is, when this is very difficult for the patients if they don't know how you are asking and what you are asking. So after years of doing this, what I do is I show the patients what I mean before I step out of the room when they lay down, and then I'm about to go and start the study and do patient calibration. I take time. It will only take about 2 minutes to show all this to the patients. Okay, once you show what you mean, the patients can quickly engage with you and do what you're asking them appropriately. They won't be asking you, well, what did you say again, right? So that just reduces the inefficiencies for when you actually show them what to do. So that's very, very important. So now after you show them how to do the paradoxical movement, you ask them to breathe normally and relax. Now you ask them to flex their toes or flex their foot. You ask them to move their foot up and down, as if flexing their toe towards their body, towards their shin. That's how you will activate and see leg EMG muscle activities to monitor how they will look if they are having PLMS. Okay? So after that's done, you can tell the patients that everything's okay, or if you need to fix any wires. Sometimes the wires are not picking up appropriately. Sometimes you need to fix the wires and troubleshoot or repair them before you actually get to hit lights out. You don't want to hit lights out and start fixing wires. Okay, you want to do that ahead of time. Okay, so if everything looks good, patient calibration is done, then what you need to do is to go into the patient's room, instruct the patient that you're about to turn off the lights, and you also ask the patient to stay on their back as much as possible. Some patients will push back and say, I do not ever sleep on my back. When you have patients like that, don't force them to sleep on their back. Allow them to sleep on their sides, just to initiate the study. After a while, when the patient is already asleep, and sometimes the patients will turn on their back and go in supine position on their own. If after an hour you still haven't seen the patient go on their back, wait until they have a short arousal, a brief arousal. And usually when they have a brief arousal, that's when you can go in and instruct them. Can you please try to stay on your back just for a few minutes? If you say that, they will oblige more easily compared to when they're still awake. And especially during deep sleep. If they have an arousal after a deep sleep, that's the time, because they usually will go back to sleep immediately after you tell them what to do. All right. Now, when you finish your patient calibration, you tell them to try to stay on your back, close the door, turn off the lights, go to your sleep system, and hit lights out. You have to make sure you hit lights out at that point in time. After you hit lights out, and typically you will then test for impedance check. Impedance check is just to show that all of your sensors and electrodes are within the appropriate resistance or impedance. So the appropriate resistance or impedance on the EEG and EOG channels, even the legs, should be below 5,000 ohms or 5 kilo ohms of resistance. On the legs, it is still acceptable if your resistance or impedance is at 10 kilo ohms. But on the EEG and EOG, it should be under 5 kilo ohms. Okay, once you finish that and you show that your impedance is good to go and appropriate, then you just monitor the patients. And you address the patients if they need anything. They need to use the restroom, you have to annotate. Every 30 minutes I annotate what stage of sleep they're in. Are they snoring? Do they have any events? Do they talk? Any observation, any arrhythmias. Okay, so any observation. When you finish the sleep study in the morning, before you wake the patients up, you typically do another calibration, patient calibration. It's not required. Typically, 1 is enough, but 2 is even better, because you are trying to show that your sensors are still within the appropriate impedance level, even though you're about to finish the study. It makes the credibility of your study, the quality of it, very high. Okay. So on that note, after doing the study, What else should you do? What else should you know? What else do you have to have in your arsenal of tools as a sleep tech? Well, scoring, like I said earlier, should be done by the sleep tech. I usually score all my studies throughout the night. So before I finish my shift, I already finished my report. If not, then you can also pass the scoring to a day tech who actually scores for a living. So you can be a day tech, you can be a scoring tech. That's also another job. On that note, the other things you have to be good at as a sleep tech is scoring and report generation and creating a substantive narrative or a story for the doctors to read. I always write a narrative about a patient. I usually state there, patient slept mostly supine, observed PLMS and arrhythmias or no arrhythmias or normal sinus rhythm, no PLMs noted, patient had frequent arousals, things like that. Then lowest saturation is this, etc. Any apneas, did you split the night? So create a very short but substantive narrative or summary for the doctors to read. Some doctors will read the whole sleep study, and some doctors will just look at any epochs that you highlight in your narrative or report. Let's say you found some VTAC, but it only happened on epoch 300, what have you. Then annotate that, and the doctors will look at it, and then they'll move forward. Other doctors will completely reread everything, and some will not. I know mostly doctors, they don't read the entire sleep study because you already did it. Okay, so on that note, the report generation is important. The other thing you need to do as a tech is to know how to appropriately disinfect all of your sensors. All right, many labs now, due to COVID, throw away the tubing, give away the masks. Okay, we also throw, like in our lab right now, we throw away everything, all the EEG, EOG, EKG. The belts are disposable, the humidifier tubs disposable, the pulse oximeter probe is disposable, but in other places those are disinfected. Now for disinfection, you can use either Sterad or another thermal disinfection such as pasteurization. Some items can be disinfected using autoclave, but not all, because they can get burned and get deformed. Now for most labs who save money, they use chemical disinfection. So usually they will run the wires, the EEG, EOG wires, under really hot water or boiling water. They dip it in there, leave it for a couple of minutes. When they take it off, then they wipe everything with Cavicide. Cavicide is important because it has glutaraldehyde. Glutaraldehyde is a key component in disinfecting with high level disinfection. Sleep products are considered respiratory, and so you need to clean it with high level disinfection or disinfectant. So the key word is glutaraldehyde for that. When you use that kind of chemical compound, then you are good to go. It's within standards. If you use other, just alcohol and or control 3, which are not considered high level disinfectant, then you need to use another disinfectant to accompany that medium disinfectant. You can't just rely on the medium disinfectant. You have to have either one high level disinfectant or at least two medium level disinfectants. After that, you store things. You have to keep the lab neat. Then the housekeeping comes in, or you take out all the bed sheets, etc. You throw it where it's needed to be. You leave the lab the way you saw it. It should be neat for the daycare to come in, and the daycare should leave it neat for when the night techs come in. But that's just not part of the actual core competence of a sleep tech. When we talk about core competence of a sleep tech, there are 11, and it's in the AAST website. These core competencies include knowing how to apply oxygen or supplemental oxygen, know how to use capnography. You should know how to score and do a sleep staging. You should know how to prep. You should know how to approach patient with the difference in age. You should know how to take care of pediatric, adult, and geriatric patients. Okay, the legalities of it all. You should also know the different disorders. You should know correlation of diseases, because patients will ask you these questions. You should know how to fit a mask appropriately. You should know how to troubleshoot your system and your patient when they have complaints on their PAP or on their recording. You should know about allergies. You should know about medications, okay, and medication interactions. Some legal components when you give patients sedatives in the sleep lab. That's why many sleep labs do not give medications to the patients, because it can be a legal issue. Okay, when you give medications to the patient to help them fall asleep, you need to be able to hold that patient until they are fully awakened in the morning. If they leave the sleep lab and you gave them sedatives the night before, and that sedative still has some after effects when they leave the sleep lab and they get into an accident, they can sue the sleep lab. Okay, on that note, that's been a long, I think, run of a text roll. Hopefully this helps. Hopefully this gives you a comprehensive understanding of what a sleep tech needs to know and or do, because this whole talk right here, this is about 40 minutes. It encompasses pretty much everything that we do in the sleep lab. And if there's more that you do, then that's good on you, especially if you're going for lab management, etc. But if you are just maintaining yourself, or you just want to get into sleep technology, or you're already sleep tech and you just want to make sure that you are doing enough as a sleep tech, and you're meeting guidelines and you're meeting criteria and you're comparable to a US sleep tech, I think I have already discussed all that. On that note, hope this video helps you. Hope that that it creates questions for you, that you will reach out to me so we can discuss and elaborate or explain things. And if you find anything that's wrong with what I said, feel free to correct me, and we'll go and research the correct information together. Other than that, this is Kem from Night Shift Academy. Thank you for listening.